So, good evening, everyone. We are coming to the last talk in breast cancers today, and our speaker for the evening would be Dr. Vinita Goel. Dr. Vinita is well known in our community, and she has done her MD from Tata Memorial, completed her MD in 2001, and since then she has been working in Delhi. I'm correct, Dr. Vinita,
Yes,
and
yes.
she now. Chief Consultant and Director of Radiation Oncology at Fortis at Shalimar Bagh. She is working at Shalimar Bagh. And I invite Dr. Vinita. She will be talking on the technicalities and um, how to do motion management, how to account for motion management in radiotherapy of breast cancer. Over to you, Dr. Vinita.
So first of all, my gratitude and thanks to the entire team who's organized this teaching course. And at the same time, I would like to convey my gratitude to all the students and everyone who's in the audience today. I mean, Saturday evening, nobody is really keen to listen to these kind of lectures. But for those who have joined, my kind regards and thanks to you. So I will be talking about inspiratory breath hold based radiation therapy techniques in breast cancer. We have to understand that breast cancer, as oncologists, we understand that it is one of the most cancer common in women. Now, with improvement in treatments like surgery, chemotherapy, targeted therapy, anti-HER2 therapy, and a lot of other things, number of patients who are surviving breast cancer or breast cancer survivors are increasing. So if you look at this graph here, you can see that UK is expected to have 1.7 million breast cancer survivors by 2040. That's a huge number. So this is the entire demographics of the entire expected number of breast cancer survivors, and of which, just one second. So this is the entire expected number of cancer survivors in 2040 in UK, and of which 1.7 millions are going to be breast cancer survivors. So there are huge survivorship issues that are being highlighted and discussed and planned world over. Now, 90% women who have localized non-metastatic breast cancer, they get local and regional radiation therapy, where there is some radiation which goes to the heart as well. And we all understand that benefits of radiation therapy in breast cancer are manifold. For example, the local regional control rates are better, survivals are better, but then sometimes they get compromised by increase in the non-breast cancer related deaths, and some of which are cardiac in origin. So it is now being highlighted as a key survivorship issue as far as role of radiation therapy in breast cancer is concerned. So this is a study by Sarah Derby. Sarah Derby, as many of you would know, is a biostatistician. Everyone who is in the audience and students, you must know this paper. I'm sure this can be easily asked to you in your vivas or theory exams. And otherwise also, you should know it. So they did a study to identify the risk of ischemic heart disease in women after radiation therapy for breast cancer. It was published in NEJM in 2013. So it was a population-based study of the major coronary events in breast cancer patients who were treated with radiation therapy. They included close to 2,000 women who were treated with radiation between 1958 to 2001. And they came out with this graph and a conclusion saying that the rate of myocardial major coronary events increases by 7.4% for each 1 gray increase in the mean heart dose with no apparent threshold below which there is no risk. So what does that mean? So for example, if my patient is getting a mean heart dose of 4 gray versus 5 gray versus 6 gray, for each gray increase in the mean heart dose, there is a 7.4% increased risk of major coronary events. The last line says that there is no apparent threshold below which there is no risk. So we do not know which is that dose below which there is no risk. Whether it is 2 gray, whether it is 3 gray, whether it is 1.5 gray is not known. Ashutosh, I hope things are fine. My slides are moving and I am audible to you.
They're fine. Please go ahead, ma'am. They're quite fine.
Okay. Now, in this study, they showed that the events of major coronary events, 44% of the events occurred in the first 10 years. I will come back to this figure once again later in my presentation. 33% occurred in 10 to 19 years, and approximately quarter occurred as late as 20 years later also. Now, there are several risk factors for these major coronary events, left breast cancer being the topmost. And then it is more common in women who previously had a history of coronary artery disease, women with diabetes, women who have COPD, women with high BMI, and smokers. So these are additional risk factors which increase the risk of myocardial events or major coronary events in these patients. How they came, how they made this conclusion is also very interesting. They did a radiation dosimetry. Individual RT charts were picked up, diagrams, photographs, treatment fields, everything was copied, and virtual simulation and planning was done on a CT scan. And they sometimes also looked at the manual planning, and they remade the DVH and calculated the dose to the heart and the coronary artery. Now, this is certainly a historical data. There are a number of women who did not receive the modern chemotherapy which our patients get today, including anti-HER2 new therapy and anthracycline-based therapy. And in this study, they found that LAD dose did not correlate with the major coronary events. So there are several limitations in this study. It's a retrospective chart review kind of a study. Nevertheless, despite all the limitations, it did show that any reduction in the cardiac doses is likely to give benefit to the patient. For example, in this first graph, you can see that this is cumulative risk of death from ischemic heart disease. Patients who have at least one risk factor, patients who had no cardiac risk factors. Look at radiation therapy with a mean heart dose of 10 gray. This is the risk of ischemic heart disease. Patients with a mean heart dose of 3 gray. This is the risk. And patients with no radiation therapy, this is the risk. So any reduction in the heart dose is meaningful and is welcome. So what does actually radiation do to heart? Radiation basically causes microangiopathy of small vessels and macroangiopathy of coronary arteries, which ultimately lead to pericardial fibrosis, myocardial fibrosis, coronary artery disease, and ultimately ischemic heart disease. So it's a spectrum of diseases which can occur because of the radiation-induced heart changes. So we have understood that it is the breast cancer survivors are increasing. Cardiac doses and cardiac exposure because of radiation is a key survivorship issue which is being discussed world over. It is important to save the heart. And, fortunately, we all have the techniques and technologies by which we can spare the heart. So, for the purpose of understanding, I have divided the cardiac sparing breast radiation therapy into two parts. So one is motion management based strategies and the other is non-motion management based strategies. For example, if you read the papers, if you read the START trial, START A, START B trial, they often talk about cardiac shielding. So for left breast cancer patients, they used small lead blocks on cobalt to shield the apex of the heart. In modern times, you can even use MLCs sometimes if it is not causing a lot of, underdosing in your volumes. Especially say a patient who had a breast cancer in the upper central quadrant or lower outer quadrant where it is safe to shield the heart by using blocks and MLCs, then this can be one strategy. The other simpler strategy can be patient positioning. So if you position the patient prone, then the heart actually, the breast falls away from the chest and there is a distance which is created between the heart and the breast. Partial breast radiation therapy or interstitial brachytherapy is another technique of sparing the heart. Other techniques which are more resource intensive could be IMRT and proton beam therapy. They are also known to, have a cardiac sparing effect. What we are going to discuss today is the motion management based strategies to spare the heart. So broadly, again, there are two types. One is gating, the other is breath holding technique. In gating technique, what we do is we generate a waveform. We ask our patients to take a normal breath and we identify in which phase of respiration, which gate of respiration the radiation beam would be on, whether it will be from 30 to 80 or 40 to 80, something like that. Gating has now fallen out of practice and out of favor for treatment for breast cancer. And the key reason for that is that when gating-based radiation therapy is given, then the time taken is very, very long, which means sometimes a patient ends up spending 1 hour on the Linac couch for getting gating-based radiation therapy, which is very, very tiring for the patient and very, very resource intensive. in 1 hour, you can easily treat 4 or 5 patients, in the same time. Now, breath holding based techniques are more, they are more quicker to deliver. So that is why, and they are more easier techniques. So they have now gained much popularity and getting nobody, I think, practices now. These breath hold based techniques are also several techniques. So this is the list. So one technique which you might have all of you might have heard of is called as active breath coordinator, ABC, which is available in the Electa Linux. It's a spirometer based system. There are other commercial softwares and hardwares also which are available for spirometer based breath hold based technique, which are called as SDX technique. The second technique, which is non-spirometer based voluntary breath hold technique, is called as RPM based technique, which is available in the variant linear accelerator. The third technique is surface guided radiation therapy, and the fourth technique is laser based voluntary DIBH. So in this picture, I have just tried to show a collage of all the techniques. Don't worry, don't get worked up. I will be telling you the details of these techniques individually because that is the key agenda of today's talk. Now, first let's understand what is the basis of why are we trying to do breath hold based radiation therapy. Breath hold based radiation therapy requires that a patient takes a deep breath, deep inspiration, and holds breath at a specific threshold for every radiation field, and only when the patient is holding their breath in deep inspiration, then the radiation beam is put on. So what happens is when the patient is taking a deep breath in inspiration, the lungs get inflated with air. So when the lungs get inflated with air, then the heart gets pulled, the lungs expand, and the heart gets pulled posteriorly, inferiorly, and more away from the breast and the chest wall. I have tried to show this here. Look at this picture. So this was the normal position of the heart in free breathing. Now, when the patient takes a deep breath, the lungs inflate with air, the lungs come here, and the heart gets pushed posteriorly. If you look in the coronal section, the heart also gets pushed down inferiorly towards diaphragm. So then you have a physical space which is created between the heart and the breast as well as chest wall. So that is what helps you spare the heart better. Coronary artery generally lies on the left, surface of the heart, left and around the left ventricle, and this area you can spare better, as well as the cardiac doses, chamber doses can also be decreased. Just please pay attention to this coronal image, which is a combination image of breath hold and the free breathing CT scan in a coronal view. So the heart also goes down inferiorly, and that is why we all practice breath hold based radiation therapy even for our lymphoma patients, where sometimes we have to treat mediastinal lymph nodes and we get advantage in sparing the heart in these patients. So that is the basic concept why we want to do breath hold based radiation therapy. So we all know that in radiation therapy, IMRT is almost considered as a milestone in radiation therapy in 21st century. I would say the second milestone is probably breath holding or gating or motion management. That is another milestone. So as I mentioned just now, the basic premise is that there is reduction in the dose to the OARs like heart, LAD. LAD stands for left anterior descending coronary artery, as well as lungs. Apart from that, DIBH also creates a static situation. There is no target movement. There is no deformation. So it's a static position of the heart, lung, breast, etc., which makes radiation therapy be delivered with better accuracy. Now here, for those of you who have not seen, this is the RPM waveform, which is seen in the variant Linacs. Sorry. So this is showing the normal inspiration and expiration, while this is showing a deep inspiratory breath hold, because here the respiratory waveform has become flat at an amplitude of 1.6 centimeter. So I'll come to this later on also. You must get yourself familiar with these waveforms. So we know that it is likely that breath hold works, but what do studies say? So this is a compilation of a lot of studies which have looked at the reduction in the mean heart dose, comparison between free breathing versus breath hold based radiation therapy, and there is, on an average, there is a reduction from 37.5% to up to 75%. So we can comfortably say that at least there is a 50% reduction in the mean heart dose between breath holding versus free breathing. There is also a meta-analysis which looked at the 12 observational studies where around 1,000 patients were treated with either DIBH or with free breathing, and they compared the target coverage as well as the doses to the heart as well as LAD. This meta-analysis was published in 2019, and this showed that implementation of DIBH for left-sided breast cancer can significantly reduce the doses to the heart and coronary artery without any compromise in the target coverage. So we have evidence to say that reduction in the mean heart dose is possible, is feasible with breath hold based radiation therapy. And Sarah Derby's paper has already shown us that every 1 gray increase in the heart doses increases the chances of coronary events. So if you are able to decrease the heart doses, then probably we can reduce the cardiac events. Now I will come to all these techniques a bit in detail. So first technique that I'm talking about is called as spirometer-based breath holding technique. In Electa, this is called as ABC or active breathing coordinator. It is also a forced breath hold. I will try. It is not easy to explain this, through a lecture, didactic lecture, but I'll try my best to explain it. This technique of ABC was developed by William Beaumont Hospital from Michigan. In this technique, what happens is that I'll first show you a picture so that you'll understand. So this is the setup of ABC. In ABC setup, patient's nose is clipped, which means patient is allowed to breathe only through the mouth. Now, in the mouth also, there is a mouthpiece attached through which patient has to inhale as well as exhale. This mouthpiece is connected to a digital spirometer and has a valve inside it. So once patient is holding breath to a desirable level, which is already prefixed as per patient's capacity, then the valve inside this tube gets closed, which means patient cannot exhale. So you're forcing the patient to maintain the deep inspiratory breath hold. Now, suppose patient gets uncomfortable, then the patient has a stopper in her hand. There is a button in her hand. Moment she releases that button, the switch and everything opens and patient can easily breathe normally. So it's an automatic system. This mouthpiece, which is valve, which is connected to the digital spirometer, creates the waveform of the breathing pattern of the patient, which I will show with more pictures. So I will come back to my previous slide. So this technique of ABC was initially developed by William Beaumont Hospital, Michigan. Patient has a mouthpiece through which she or he breathes. This mouthpiece is attached to a digital spirometer, which records patient's real-time breathing waveform. Patient's nose is clipped to ensure that they are breathing only through the mouth. Another thing which I forgot to mention, patients are given prism eyeglasses. Now, the purpose of prism eyeglasses is that even when the patient is lying down on the couch, through these prism eyeglasses and reflection, patient can see a computer screen on which her breathing pattern is being plotted in real time. So she knows whether she is holding the breath at the correct point or not. She can even see how much time is left and how much more time she has to hold the breath. So this is called as forced breath holding. I'll show you some more pictures and try to explain once again. So this is, a picture which is showing that this patient is holding the mouthpiece in her mouth. Her nose is clipped and she's wearing these prism eyeglasses. Through prism eyeglasses, she can see a monitor which will be somewhere here on which her respiratory waveform gets plotted. So this is how the screen looks like. So this is, where the patient's head would be, and she can see the screen and she can see her waveform. So the patient is getting a constant feedback. Suppose I have to hold my breath every time at the same time point, at the same amplitude. It is very difficult unless I get a feedback whether I'm at the right spot or not. So Electa ABC has this system which gives a real-time feedback to the patient in the form of waveform. So once I, do- I'll just show you this also. So suppose you have a patient who's suitable for breath holding, then you first train them to do breath holding. Then you acquire a CT scan in the breath holding position. Then you do planning in the breath holding position. Then you do plan evaluation, QA. And then when the patient comes on the machine, then you have to take a CBCT or cone beam CT scan of these patients to ensure that the heart and the lung position as well as the position of the target volumes is same. So this picture is actually showing a Electa ABC cone beam CT. So when the patient is lying down on the couch, a partial CBCT is taken in the breath hold. This is showing the two colors because it is a combination of the planning CT scan and the CBCT. So the green area is the area where there is a slight mismatch, but you can see that there is a reasonable matching of the target as well as heart over here. This is a closer view of the same. I'm trying to emphasize that if you're treating your patients in breath hold, then you also have to acquire your cone beam CT scans in breath hold. You should not take them in free breathing, otherwise there will be a mismatch which will confuse you. This is a coronal view of the same breath hold based CT scan. Now we always take partial CBCT so that patients have to hold their breath for a lesser number of times. This is the axial view, and you can see that the match is quite good. Now there might be somebody say who has a Toshiba linear accelerator and wants to practice spirometer based breath holding technique for her breast cancer patient. Then there are, other than ABC, there are other commercially available spirometer breath hold systems are also available. For example, there is a STX system. If I'm correct, I think this system has been purchased at Apollo Chennai because they also do IMPT for left breast cancer under breath holding technique using this hardware as well as software. So you can see that they have a different kind of something like virtual reality goggles are there through which patient can see her waveform. The nose is pegged and there is a mouthpiece. So it's a very, and this is the waveform. So it's a very, very similar kind of a system. They have on the screen, the patient can see green as well as red colors. So the green color means that the patient is holding the breath at the right point. Earlier, when the breath holding based hardwares and softwares were coming, they were not there with the visual feedback to the patient. And so the reproducibility of the setup was relatively poor. So I have talked about first system of breath holding, which is also called as forced breath holding, and it is also called as ABC or spirometer based breath holding. Now the second system which is used for breath holding is by the company Varian. It is called as RPM based system. It is also called as voluntary breath holding technique. I will try and explain this also. This technique was initially developed by University of California and Varian Associates together. Now, in this technique, there is an infrared marker. There is an infrared camera, IR camera, which is mounted at the end of the couch, or it is mounted from the ceiling. So this is actually a picture of the CT simulator. So the RPM camera is actually mounted at the feet end of the CT couch, or else in the linear accelerator, it can be ceiling mounted also. Then there is a marker box which has infrared markers. So this marker box is placed at the xiphisternum of the patient at the junction of chest and abdomen in the center. And when the patient is breathing, this camera is looking at this marker and detecting its relative position as to how this marker is moving up and down with inspiration and expiration. Using this information of movement of markers, which this camera is capturing, it generates a respiratory waveform. The respiratory waveform is quite similar to how it is generated in the spirometer based system. It includes inspiration, expiration, and when the patient is holding the breath, it certainly includes a plateau kind of a breath holding based waveform. Now, this is a goggle which has been recently introduced by Varian in the TrueBeam, I think version 2.7 or 2.6, where the patient can actually virtually see the respiratory waveform. It is connected by Bluetooth with the monitor on which the waveform is being projected. So I'm coming back to my previous slide. So the Varian RPM system is also called as voluntary breath holding system. It was developed by University of California and Varian Associates together. It has an infrared camera which is mounted on the wall or it is mounted on the couch of the treatment unit. There is a marker box with reflective dots which is placed on the patient's upper abdomen during breathing. This infrared camera detects the marker box and calculates the position and movement of the thorax. This respiratory positioning management system or RPM tracks this external marker block, which is a surrogate for internal movement. So by capturing the movement of the of this marker box, we are trying to understand what is happening in the lungs, whether they are expanding or contracting. Now, in this patient voluntarily breathes, there is no mouthpiece. So the patient, there is no spirometer, there is no valve. So patient voluntarily breathes to the required threshold and holds the breath in the deep inspiration. And sometimes these virtual reality goggles or display goggles are available. Sometimes they are not available. Okay. Now let's look at the comparison. What are the let's understand what are the advantages and what are the limitations of spirometer-based ABC, which is available with Electa and SDX system. So the advantage is that there is a mouthpiece, there is a spirometer, which helps fix patient's volume, breathing volume, as per patient's capacity. For example, if I have a lady who can hold her breath up to the amplitude of 0.6, I can do up to 0.6. If there is a lady who can hold it up to 1 liter, I can hold it up, make it up to 1 liter. So you can fix the patient's breath holding volume as per patient's capacity. There is a breath control trigger which ensures treatment disruption in the event of unexpected situations, which means patient is holding that switch in the hand and she can release it in case there is any in case there is any problem, while the treatment is going on. The biggest advantage, as I see, is high reproducibility. I have personally had the fortune of using both variant-based system as well as ABC spirometer-based system. The spirometer-based system is a very, very user-friendly system. When I was working in the variant system, I used to say that if I train 10 women to do breath holding, 7 out of 10 will be able to do it. When I have moved to ABC, I say that 9.5 out of 10 will be able to do it. My own personal experience says I treated one young boy with Ewing sarcoma of lung using ABC. His age was 8 years old. I have also treated one breast cancer patient, 78 years old, and another gentleman with liver SOL using ABC-based SBRT. So the age range is quite wide because it is a very user-friendly system. But then there are disadvantages. The disadvantage is that it is uncomfortable for some people to hold that, earpiece, mouthpiece, and get the nose clipped. It is certainly not suitable for patients who are claustrophobic and patients who are anxious. Now let's also similarly look at the advantages and limitations of RPM-based system, which comes with the variant, which is also called as VDIBH. That is non-invasive. It is more comfortable. There is a automatically beam turn on and turn off when the inspiration is in or out of the fixed threshold. Suppose you have fixed the threshold for a particular patient and patient breathes, takes a deep inspiration, but then slowly releases her breath, then the machine automatically turns off. The disadvantages or the caveats are that there is no mechanism to help patient hold the volume there is nothing which is helping the patient, hold that deep inspiration. We are again using chest and abdominal wall as surrogate to generate the respiratory waveform, and it may or may not ensure adequate lung expansion, which means what? When you take a CBCT, when you generate a waveform, you find that the patient's waveform is perfect. But when you take a CBCT, you find that the lung has not expanded because this marker box is lying on the abdominal wall, patient did the abdominal breathing. So the abdomen expanded, the waveform is correct, while the lungs have not expanded and the heart has not gone inside. Can sometimes happen with this technique. Now, despite pros and cons, in dosimetric studies, both the systems have been found to be comparable in controlling the mean heart doses as well as the dose to the LAD. Both systems are comparable. Now, let's come to the third system. So I'm trying to, share with all of you that there are several systems which are available for doing breath hold based radiation therapy for breast cancer. The third system that I'm talking about is the surface imaging system, SGRT, surface guided radiation therapy. So in this, there is no X-ray, there is no imaging. It's a non-invasive technology which is used for continuous or real-time localization of the patient during radiation therapy. It also comes by the several vendors, Align RT, Vision RT, Catalyst, Identify. These are some of the vendors or the software hardware names by which it is available. By principle, in this, there are 3 cameras which are focusing on the patient's breast oblique chest wall, and they monitor the breast and the chest wall excursion, and they compare this real time with the vertical displacement of surface position as compared to the surface position generated by the planning CT scan. So during treatment with DIBH, surface tracking is done and is used to guide the patient. So since there is no imaging, there is no CT scan here, so there is no radiation dose, additional radiation dose. So this is the kind of setup. This is how the patient lies down here, and there are 3 cameras which are generating this colored picture of the patient's surface you can see here, and this kind of image or heat map is generated. So it calculates the displacement in all 6 degrees of freedom. Then there are other similar systems also which are available by the name of Catalyst and Identify, which also work almost on the similar principle of surface guided radiation therapy. There are certain limitations of surface guided radiation therapy. First limitation is that patient's skin surface should be visible to the system, which means you cannot have an orbit. Certainly you cannot have an orbit because the system has to see the surface of patient's body. Now, again, like the variant RPM system, here we are using surface of the skin as a surrogate for internal anatomy, which may not always be correct. The third challenge is that there are 2 images which are being generated. The reference image is generated from CT scan, planning CT scan, while the daily image is generated by the optical system or the light source. So these reconstructions are actually fundamentally different and can sometimes lead to some kind of an error of judgment. The advantages of surface guided radiation therapy are that there is no radiation exposure, no additional radiation exposure. There is a real-time monitoring and correction of any intrafractional setup errors. However, it does not verify lung expansion. So I think it should be used as a system which is complementary to ABC and RPM, although I have no personal experience and my judgment might be wrong about SGRT. The fourth technique, which everyone should also know about, is the laser-guided voluntary DIBH. So normally we position our patients on the treatment couch and we mark the lasers. You all mark lasers. You mark the sagittal laser, you mark the coronal lasers on the patient. So you do 2 laser markings, one with red pen, the other with green pen or a black pen. So first laser marking you have to do in the free breathing position. Patient is breathing normally. You again ask the patient to hold the breath in deep inspiration and again mark the lasers in the breath holding position. So this marker position, laser marking position, is going to be different from the free breathing position. And then you have a camera. This camera is looking at the laser position and is showing you how the patient is holding the breath. So this is the free breathing, and this is the laser marking in the breath hold position. So once you can use the lasers to guide and treat the patient in breath holding. It does not require any additional resources. It just requires that you have to understand the process and carry out in your department. I will just show, for those of you who want to actually start the breath hold based radiation therapy in your respective departments, please go through this interesting series of studies from UK. It is called UK Heart Spare Study, from research to implementation. They did 1A study, 1B study, 2 study, and now another study is coming. I'll talk about that also. So in 1A study, they compared voluntary DIBH versus ABC. In 1B study, they compared prone versus supine voluntary DIBH. And in study number 2, they compared whether this is a implementable technique across all centers in UK or not. So in heart spare study 1A, they compared ABC versus voluntary DIBH. Okay, I'm sorry. So they compared the interfractional reproducibility, OAR doses, target coverage, radiographer satisfaction, time, cost, etc. And it's a small randomized study. The study did not show any dosimetric difference between ABC and DIBH. So the same heart dose which you can achieve with ABC can also be achieved similarly with the voluntary DIBH. However, their technologists and patients, they liked VDIBH more as compared to ABC. The limitation of this study is that small number of patients were actually evaluated as a part of this study. Now, after study 1A, when they realized that VDIBH or voluntary DIBH is something that they would like to go ahead with across UK, then they compared VDIBH with prone position for patients who had large breast size with a breast cup size of D. Again, the premises are that, in voluntary DIBH, you are trying to create a space here, while in prone position, the breast falls away from the chest wall and the heart. So when they analyzed this study, they found that DIBH scored over prone position in comparison for the heart doses, LAD doses, left lung doses, etc. So they found that VDIBH in supine position is a much better technique as compared to the prone technique. Now, after they had made up their mind that VDIBH is better than ABC and also prone, then they did a UK Heart Spare 2 study, which is a non-randomized feasibility study of implementing VDIBH across multiple centers in UK. 101 patients were treated in 10 UK centers, and the primary endpoint was the percentage of patients who are getting a reduction in mean heart dose with voluntary breath hold. And they found that 95% patients achieved a meaningful reduction in the mean heart doses with VDIBH. So they found that VDIBH or voluntary breath hold is an effective technique and is also implementable, feasible technique in multi-center technique. For those of you who want to implement or start voluntary DIBH in your center, you can go through their processes and protocols. They are very well written and guide you a lot. How they also implemented laser-based breath hold technique, which does not require any resources. So in case you do not have RPN system from Varian or ABC system, you can still do laser-based technique. I am aware that for some time, Jaslok Hospital Mumbai and Apollo Hospital Kolkata for some time were using laser-based breath hold technique. It is a doable technique. You can easily find the details of that in the UK Heart Spare protocol, study protocol. Now, apart from this, the UK people also realize that now there is more image-based evaluation of patients of breast cancer. For example, some patients will have CT scans, some more patients will have PET scans. So we are detecting more IMC lymph node. Now, when you're treating IMC lymph node, certainly the dose to the heart and the lung dose goes for a toss. So now they are doing another study, which is called as Heart Spare Plus study, which is looking at the implementation of VDIBH and reduction in the heart dose, especially for patients who require radiation to the IMC. This study is right now ongoing. This is an ongoing protocol. So by talking about all these techniques and heart spare protocol, I'm trying to give you all a message that all techniques are effective. Let's not find an excuse. We must use available resources at hand. It is essential for all of us to practice this. So I'll share with you a very interesting case report which I read in Radiation Oncology Journal a few years back. So it's a case report of a 53 years old lady who had carcinoma of left breast. She underwent MRM and she was a heavy smoker for 40 years. The investigators or the people attempted DIBH. However, it failed because she had shallow and quick breathing. But then they realized that she was using CPAP for sleep apnea. So they treated her with CPAP. So this was her free breathing scan, and this was her scan in the CPAP position. So CPAP is exactly doing what DIBH would have done to her. So I think hard, find your own solutions, but do look at the feasibility of doing this. So let's talk about who is the right candidate for DIBH. I will say you have to remember that DIBH is a patient-driven treatment. Patient is sitting on the driver's seat of the breath hold based radiation therapy. It is not that patient has to go lie down, the technologist will put the cast. No, the patient has to hold the breath either by forced method or voluntary method. So I think the patient factors are very important. I think all patients who have left sided breast cancer should be considered for DIBH. Some consider that, because the heart related side effects occur 10 to 20 years later, a lot of people think that it should be offered only to women who are less than 60 years in age. I slightly disagree with that. Anyhow, that's a personal call. You also have to look at the treatment resources available and allocate them suitably to all your patients. I think DIBH should be considered for any patient who has IMC lymph node radiation requirement, irrespective of whether it is left side or right side. Patients should be able to understand your instruction. Patients should be able to tolerate the procedure. The procedure, even VIBH, takes about 20 to 25 minutes. So they should be able to lie down on the couch for that long. They should be able to hold their breath, reproducibility. Any patient who is at high risk of ischemic heart disease should be considered for this technique because the heart dose matter more in these patients. Patients who are being treated for bilateral breast cancer should be considered for this. Patients who are getting re-radiation should also be considered for breath holding based radiation therapy, or patients who have unfavorable anatomy. For example, patient who has a large heart, bade dil wale log, cardiomegaly, or thighs like chest, or pendulous breast, or where there is a tumor location at extreme medial or lateral end in the lower half of the breast should be considered for this technique. So this is a scan of a lady who was young who came to me with right-sided breast cancer, but she had an IMC node in the third or fourth intercostal space, and we did treat her with DIBH to spare her heart better. Similarly, look at this patient. She was being treated for bilateral chest wall radiation. Here, the heart doses contributed from left side as well as right side. So if you use DIBH, you get advantage in terms of sparing heart as well as lung for these patients. So I think this is another beautiful indication of DIBH. Some people also take a free breathing scan, before offering DIBH and calculate what is called as cardiac contact distance to identify who is likely to benefit with DIBH. So in this scan, what you have to do is you ask the patient to, you take a scan of the patient in coronal, axial, as well as sagittal views, and draw a line from the apex of lung to the diaphragm. Then draw another line at the level of the diaphragm. At this section, at this intersection, look at the axial scan and calculate from mid-sternum to the heart the contact distance in axial. If this contact distance is more than 5 centimeters, the area of contact between chest wall and the heart, then these patients might benefit from breath hold based radiation therapy. Similarly, look at the sagittal section in the same plane and measure this distance for area of contact between the heart and the chest wall in the sagittal plane. And if this distance is more than 2 centimeters, then these are patients who are likely to benefit, with breath holding based radiation therapy. Now, I think I'll skip this. Who should not be considered for DIBH is also very important. So if your patient is very old and frail, patient is not motivated, patient has hearing disability, patient has come from Andhra Pradesh and you're treating her in Haryana and she will not understand your language, don't attend. If there is a language barrier, don't attend. Or if poor performance status, patients who have arthritis, wheelchair bound, this is a patient driven treatment. These patients cannot carry out this kind of long treatment. So please don't consider them. Yes, I think for any patient who's being considered for voluntary breath hold based radiation therapy, education and training definitely helps. So in my previous institution, we created this kind of a information sheet for the patient, and we would pass it to them to explain them the procedure and the potential advantages. So this kind of things help. Sometimes we also called our old patients to teach or train the new patients or encourage them to follow this technique. There are some very interesting things which I have learned while I have been practicing DIBH for my patients. We encourage our patients to go for yoga, walk, spirometry. Some people know balloon blowing. So I asked them to do balloon blowing. So recently we had a very interesting lady. She was not able to understand how to do DIBH. So her husband said, तुम तो सोचना कि नाक बंद करके you close your nose and you're taking a dip in Ganga ji, in Ganges river. Ganga में तुम गोता लगा रही हो. So she understood that. So I think whatever works, works. Try it. I had this another young lady. She was not very comfortable with DIBH. And she said, Doc, I used to smoke earlier. What if I start, assuming that I'm taking a deep puff? I said, do whatever you like. So you need to invest some time with your patients. What you actually need to do is, as doctors, you may not always have that much of time for training these patients or hearing them out. You need to train your technologist staff. You need to identify those smart boys and girls who can train your patients, to do this technique. I generally tell my patients that, when they're coming for breath holding based radiation therapy, they should have a light meal prior to the session. If stomach is full, then the diaphragm gets pushed up and holding breath becomes problem. If you're giving a visual feedback to the patient, it certainly improves their reproducibility and confidence to do breath holding. I also suggest that aim for moderate breath holding. Do not aim for deep breath holding because, by the end of the treatment, they get very tired. So aim for moderate breath holding and not deep breath holding is what I suggest. 1 second. So suppose for some of the patients, to motivate them, we also show them a comparison of their free breathing and breath hold based scans so that they understand the benefit. Once they understand the benefit that they are getting, then they get motivated. And sometimes we also keep the mock-up fraction of fraction 0 on a free day or a Saturday so that we can give them more time on the machine so that they understand. This is a very important picture. I had learned this from Dr. Tabassum from TMS. She told me that, when I was starting to practice DIBH, she said, make sure that your patients are not lifting their back because then the setup may not be reproducible. So the back has to be aligned, along the frame or the couch while they have to lift their chest and expand their lungs. Anyone who's practicing breath hold based radiation therapy also should be able to go through all the cardiac atlases. Now let me also tell you one more thing. Mean heart dose is actually a poor surrogate. We still do not know what are the optimum mean heart doses, LAD max and mean doses, or what is probably the best left ventricular doses, what is the safest dose, we do not know. Mean heart dose is a surrogate. Now, heart is both a serial structure as well as a parallel structure. So the mean heart dose matters because it's a parallel structure. But at the same time, LAD or the coronary arteries are serial structures. Because if there is a higher Dmax to the LAD, then the chances of fibrosis and occlusion are more. It is not easy to contour LAD. Why? Because it's a small caliber vessel. Majority times when we are doing simulation, we do not give our patients contrast. So there is a new concept. This new concept has been proposed by this Korean paper. I urge all of you, those who are interested to kindly go through this paper. It tells you not to mark coronary arteries. See, coronary arteries sometimes can have, change in anatomy or a lot of tributaries, which you and I cannot identify on a non-contrast thick 5 millimeter or 2.5 millimeter scan, which is taken for the planning of breast cancer. We do not take 1 millimeter scan for these patients, right? So they say that this paper says that rather than marking coronary artery, you mark what is called as coronary artery region. So this is the region which is most likely to have the coronary artery. Very interesting paper, kindly go through this. There is another concept. This another concept is called as anterior myocardial territory. A lot of SPECT studies have shown that after patients have undergone breast cancer radiation therapy, left breast cancer radiation therapy, when their SPECT scans are taken, then they show a perfusion defect along the anterior myocardial area. And this is the same area which also has the LAD, coronary artery, left anterior descending coronary artery. So instead of marking the coronary arteries, you can mark this area, which is called as AMT or acute anterior myocardial territory or a coronary artery region, and ask your physicist to control the Dmax as well as mean in this area. So if the physicist is controlling the max here, LAD automatically gets controlled. If they are controlling max and mean here, the rest of the heart automatically gets controlled. We still do not know what is the optimal dose which is recommended for this anterior myocardial territory area. It is still not known. Dr. Ashutosh, can I take 10 minutes to explain the simulation process also?
Please, ma'am. Please go ahead, ma'am.
So now I'm going to briefly explain there is a specific process which is required on the Varian machine. So I will just go through the 10 steps of Varian DIBH process, identify the right patient.
Ma'am, sorry. While you are doing it, we have had one question relating to this, that uh, do you train the patient before your simulation or after the simulation?
No,
So
certainly before the simulation.
you can address the question during your.
So you have to train the patient right in the beginning. See, simulation is a first step, last step before you actually start the treatment. So simulation setup has to match with your treatment setup, right? So that is why you need to train the patients before simulation. Okay. So in the Varian, we used to follow these steps. First is that you have to identify who's the right patient. Sometimes after training also, you might feel that, although you thought that this is a young, fit, physically active lady and might be able to do breath holding, you might find that they do not have a very regular or reproducible breath holding pattern, or they are not able to hold their breath. Then some of these patients might disqualify for VDIBH, voluntary DIBH. So identify the patient, then do training. After training, assess their breathing pattern and assess whether the breathing pattern is reproducible or not. Then you have to do a CT simulation. When you're doing a CT simulation, it is recommended that you take both free breathing scan as well as breath holding scan for two reasons. One is that you can compare and contrast whether there is a real advantage of using the breath holding based treatment plan or not. Second is, suppose, in between the treatment, patient fails. She says, I can't do it. I'm not able to hold my breath. You already have a backup free breathing scan on which you can quickly plan and start the treatment. After simulation, you have to do contouring and planning. I will show you pictures also of all this. Then you have to set up the respiratory waveform, and you have to link it with the approved treatment plan. I think I will show you the pictures. So this is the setup which is required for Varian. You have to have a RPM camera. You have to have the marker box. 4D CT scan is not required. A lot of people think that we need a 4D CT scan, only then we can do breath hold based radiation therapy. No. All you need is a fast CT scanner, which can capture the entire scan in a breath holding 10, 15, 20 seconds. And you need a RPM system for Varian. This RPM block I showed you is put across the Ziffy sternum, and you have to mark its position with tattoo or tegaderm, because later on also after simulation also you have to every day put it on the patient's Ziffy sternum when the treatment is being done. And then this is how the waveform looks on the Varian screen. So this is showing the amplitude of the breath hold. This is showing the range, permissible range in which the patient can hold the breath, which means what? Which means that if the patient is holding the breath here, the treatment is on. If the patient is holding the breath here, the treatment gets off. You define a threshold. You see this amplitude is higher, this is lesser. Still within this range of 2 to 3 millimeter, machine will be automatically on, and you have to define this threshold. Now look at this here also. Once you tell the patient to do the breath holding, you instruct your patient from the console, लंबा सांस लेके रोक के रखिए और hold your breath in deep inspiration, then they inspire, take a deep inspiration and their breath hold plateaus. So there is a time lag between the start of inspiration and the plateau which you want to achieve. So you have to give that time gap in your machine timer also. You have to define this time. This is called as time delay. So the moment patient starts breath holding, the machine or the beam does not get on. It gets on after a certain delay. So this delay has to be defined. So when you're analyzing the breathing pattern, you have to see whether the breathing pattern is regular or not, whether you have achieved a good amplitude or not. Patient should be able to hold breath for minimum 20 to 25 seconds. Why this is important is Because, if the breathing, suppose the patient is holding breath only for 10 seconds. So 10 seconds your machine is on, then again off. 10 seconds on, again off. So then the total time on the couch gets very prolonged. So the minimum which is recommended is 20 seconds. Generally, patients are able to hold up to 20 to 25, and some will be able to hold up to 30 seconds also. Yeah. I had learned this about DIBH Orfit from, Dr. Srinivas when he was at Yashoda Hospital in Hyderabad. They were making a DIBH Orfit, which means what? Which means they would ask their patient to hold their breath in deep inspiration and make the cast. So once the patient would release her breath, then there would be some gap between the skin of the patient and the Orfit cast. Later on, when the patient is asked to hold the breath for treatment of a simulation, the skin of the breast will touch the Orfit and the patient understands that they're getting a feedback. It's a crude way, but the patient gets a feedback that probably I'm holding the breath at the right spot. It's a very simple tool and quite effective. It's optional. It is not essential or must. So this is how your RPM screen looks like. This is the patient who's holding the breath. And then you have to see for how many seconds the patient can hold the breath. Then let's come to how to acquire the CT scan for simulation purpose. So I have mentioned here that you should not be in a hurry. CT has to be acquired after adequate amount of training. On the CT scan, you will mark the laser origin or the CT origin. Now, this CT origin has to be marked both in free breathing, ask the patient to breathe normally, mark the 3 laser points, and also in breath holding. Then you acquire your helical or spiral 4D CT, not 4D CT, I'm sorry, a quick CT along with the respiratory waveform and deep breath holding. Ask the patient to hold the breath and acquire the scan. What you have to remember is when you're transferring the scan to your TPS, you have to transfer both the CT scan as well as the respiratory waveform to the TPS. The demographics of series and examination should be matching. If the patient's name is Shubhra, it should be Shubhra, Shubhra. If the UHID is 11224, 11224 in both the CT scan as well as the respiratory waveform, these are small points which we have to check. Now, before saying that your scan is all right, you must check whether what is the position of the vertebra or the spine in the deep breath hold, and check that the patient has not raised her back when the DIBH scan was being acquired. You should also compare the heart to chest wall distance in free breathing as well as in DIBH to make sure that there is a benefit of DIBH. In the variant RPM system, you have to select amplitude and breath hold when you're acquiring the respiratory waveform. After you've done the CT scan, look at this distance. Awesome distance. You see, the heart is completely gone inside you. Then you contour your target OARs, use the cardiac atlas, do your contouring, and then the planning has to be done. We do IMRT for these patients, but then we put only tangential beams. You must also sit down with your physicist and look at the BEV in free breathing as well as in the DIBH, whether the heart has completely gone out of the beam or not. Then you look at the plan and then you analyze the plan. This is the plan in which I'm trying to show that this is the reduction in the heart doses which we could get, with breath holding versus free breathing, and this is the LED doses. So you can see that the max dose of the LED significantly reduces with the DIBH based technique. Then once you have finalized the plan, then you have to link the approved treatment plan with waveform. You had imported the waveform as well as CT scan. You have made the treatment plan. You have to link both these two. Then you have to define the breath hold delay time, which I showed you earlier. And then you have to define the upper and lower threshold between which the machine will be on. Then you have to do your QA before taking the patient on machine. Then once the patient is taken on the machine, then you have to acquire the cone beam CT scan again in the breath holding position. In this picture, it is showing a full arc breath CBCT. You can even take a half arc or partial CBCT. So I think I have given you a lot of information. I hope it was useful. I want to admit that there are still a lot of gaps in the knowledge regarding cardiac toxicity because of radiation therapy. We still do not know the safe threshold dose of radiation therapy to the heart below which there is no risk. We do not yet know what is the exact relationship of radiation doses to individual cardiac chambers. This technique of breath holding is certainly resource intensive, requires more time, to train patients as well as you have to train your staff. There is increased time requirement to do this treatment on the LINAC also. But in a well-oiled system, if you're doing this regularly, then the time and the resource required are not very high, and it is worth all the effort. It is really worth all the effort. It, in my opinion, is a new standard of care for patients who have left-sided breast cancer. It is not optional. It is not essential component of their technique. And although it is still in the evolution phase, it is an excellent technique to reduce the cardiac doses as well as lung doses. And the benefit is irrespective of the technique which you use for breath holding. And I would urge all of you that don't wait for the right resources. Do whatever best is feasible in your own setup. And this is my acknowledgement to our team of physicists, technologists, nurses, and everybody who worked tirelessly with us. And I'm also thankful to Dr. Sharmila Agrawal, who had taught me about the UK heart spare study. So with this, I end my presentation and I'm open to answer any questions.
Thank you, ma'am. That was a very comprehensive presentation, ma'am. And the presentation answered actually a lot of our questions. I'll start off with one question from my side.
Sure.
So for starters or for the students, what part of the heart should I contour? Now, should I contour the whole heart? Should I just contour the apex or the apex and the anterior myocardial tent?
So Dr. Ashutosh, the standard recommendation as of now, as of today, is to contour the entire heart, because you still do not have a replacement for mean heart doses. We all know that it is not a good surrogate, but we still have to look at that. Secondly, in addition, because as I said, that heart is both a serial as well as a parallel structure, you are interested in knowing and contouring the Dmax to the heart. I would say, in addition, you can contour the anterior myocardial territory or apex of the heart and ask your physicist to control the Dmax in that area.
Thank you, ma'am. Any other quick tips, ma'am? Like the first tip you said, for matching, the common mistake is when the back is raised. Any other similar tips, ma'am? Especially if I'm doing RPM based contouring or I'm doing spirometry based contouring. I mean, not contouring, DIBH.
Ashutosh, honestly, to share with all of you, I had a tough time learning this technique. There is only one way to learn it. Start doing it. The other thing which really helps is to have your team in place. Now, by team, I do not mean only your junior or senior doctors. I mean your physicist, your technologist. Once they also understand what they have to do, your process gets absolutely easy, because they will come out with a lot of new solutions. For example, when I started practicing variant-based DIBH, we did not have the video goggles. So our physicists and technologists together, they took a tab, a Samsung tab of less than 5,000 rupees, and they hanged it from the ceiling so that it would come exactly above patient's eye through a frame, so that the patient could, see her waveform. If you're giving feedback to the patient, then things are very easy. If the patient is not getting feedback, visual feedback of how the breath holding is, then it gets very difficult. Another tip I would say is that to start with, you should choose young, fit women. People who are regular gym goers and walkers and athletes, because they are easy to train, more reproducible setup is there, so that you and your team also get enthused and encouraged, to follow it.
Right, ma'am. And also
to ask everybody to take a Gotaji in Ganga.
And one to see the level of intelligence, not be English speaking as such, but the level of intelligence. They should be able to understand the procedure, no, ma'am?
So I think majority women are intelligent. Once they know what they are going to get, once they understand, they follow it. So, one lady, she was about 60 or 62. She had traveled long distance within Delhi to come to us for ABC. But then I could see that, her energy levels were not very great. I thought, how will she do it? Then I showed her two scans and she said, Doc, I have to do it. So once you show them their own two comparison scans, they get motivated. Or if sometimes they get to talk to their somebody who's already finished treatment and they say, "Kya ye kar sakte hain," so then I can also probably try and do it. So they need a lot of counseling, encouragement, hand holding, training, everything. And these days a lot of good videos are there on YouTube.
Yes, ma'am. Yes, ma'am.
Share those
Thank,
links.
yes, ma'am. Thank you, ma'am. I think we have gone through the questions. Dr. Rashi, would you like to ask something?
Yeah, ma'am. Actually, ma'am has covered nicely the topic. But, ma'am, can you please tell if we are doing DIBH? So, how much dose is reduced when we are doing DIBH to the heart? How much we can do reduce the dose?
So, Rashi, my answer to that is that mean heart dose gets reduced by approximately 30 to 40%. Earlier, my mean heart dose used to be around 4.5, now it is around 3. But the biggest advantage is that you are able to control the Dmax of the heart as well as LAD. That's a huge advantage.
Yeah, ma'am. Thank you so much.
There's
And
a
Dr. Ashutosh, there is
a question in the chat box from
yeah.
Yes, ma'am.
There's a question in the chat box that should we be doing CBCT daily? Yes. It is essential to do CBCT daily because you have to look at the heart and the lung condition. The question by Jairam, he's asking whether IMRT should to be planned with inverse planning or forward planning. So forward planning IMRT is way better than inverse planning IMRT because the number of MUs which are delivered are also less. So the treatment gets over very quickly in fewer breath holds. TMC Kolkata, as I know, are regularly doing forward planning IMRT. But sometimes, if you have a very complex target volume, say especially when you're treating IMC, internal memory chain lymph nodes, then you inverse planning IMRT is the way to go.
Thank you, ma'am. Ma'am, what about adding 3D CRT to a DIBH?
Oh,
So instead of doing,
wonderful. It's wonderful because the TMC Kolkata is regularly doing that. And the
yeah,
biggest
we used to do
advantage
that at, yes, ma'am, we used to do that at Yashoda and we started it here also.
yeah, wonderful. That's wonderful.
So I think we are through with all the questions, ma'am. And I would again thank you for the wonderful talk.
My
And
gratitude and thanks to all of you for participating as well as giving me an opportunity.
thank you, ma'am. And I'll ask our host, Mr. Avinash, to end the class here.
Sure, sir. Thanks a lot.